award is presented to a blood service or centre from a developing country that has made a significant contribution in strengthening transfusion practice within the country. It enables blood services or centres to attend an international congress of the ISBT and to organise an educational symposium. This year's award is given to the Lifeblood Centre from Gujarat, India.
We thank ISBT for recognizing our significant contribution in blood transfusion and your remarkable work to improve the safety of blood transfusion worldwide. Thank you.
We thank from the bottom of our heart to all the officials of ISBT for presenting us the most prestigious Developing Country Award 2020.
And to all of you gathered here, this should be our take-home message, because clinical work will go on, but if we don't strive ourselves to a higher level as humans, we don't flourish. So charity and donation is a part of every human life. So thank you to my alma mater, AIIMS, where I've researched, and I'm wherever I am today as the editor of a journal or an author of 11 textbooks in cardiac critical care. It's thanks to AIIMS. So we had our Robert Bartlett, we've had our international presidents, we work with many international societies. Ours is the Simulation Society, which works on simulation. I'm just coming from Bombay, where we did ECMO simulation for more than 90 students, and next weekend the same procedure is there at AIIMS. So we work on simulators, we learn from masters. But one thing that I learned is, why were we losing patients? A colleague's father some 20 years back was being operated for aortic regurgitation, and we had him bleed to death on the OT table. As a young assistant professor at that time, it pained me to see the colleague take the father home with the valve in, but no life. And what was the reason? Our blood banks were not so equipped with so many massive transfusion ready in the middle of the night that we had to do the emergency AVR. When we use a centrifugal or a roller pump that we use for a cardiac surgery or most of the surgeries, what are we doing? We are initiating a systemic inflammatory response. And this systemic inflammatory response is sooner or later going to bring about a contact factor pathway activation of the intrinsic and the extrinsic pathway, give rise in due course of time, if not corrected, to a dilutional coagulopathy. The platelets are the nucleus of the entire hemostasis, and during surgery, if there is platelet activation and the platelet fibrin with the thrombin with the fibrin and the fibrinogen does not form a plug, which Dr. Sukesh was talking to you about, the clot forming time, which is just a few seconds. You saw it as the R time and you saw it as the angle of 35 to 45 degrees. And there's no proper retraction of this clot, and there is no proper lysis of this clot. The normal physiology of hemostasis would be disturbed, which it is in a neurosurgery, a cardiac surgery, or a liver surgery like a liver transplant or a Whipple's surgery. So knowing fully well that platelets are the nucleus, the platelet aggregation therefore today is the need of the hour. And my talk would be more clinical, away from what you've been hearing Dr. Wood talk, and more in tandem, and I thank Dr. Sukesh Nair, he made my talk very easy. So in all surgeries, whether I put my patient on an ECMO or a ventricular assist device today, my patient is on an oxygenator, which is like the lung, is on a centrifugal pump, which is the heart, and this artificial surface will bring in hemolysis. And this oxygenator over 3 to 4 to 5 days with big cannulas of return and access in the patient's body is going to give rise to the formation of small clot and thrombi. When you have this, your patient is going to bleed to death with a DIC. And this is what you, as an intensivist, as a cardiac critical care person, need to avoid with the use of a good blood bank. Discuss the patient with them. That teamwork is what takes you into saving many lives. So functional hemostasis, contact active pathway of both starting from 12 to 12A and coming to this contact factor pathway, the common factor here at 10A, and the tissue factor platelet inhibitors with the extrinsic pathway also coming here. What is happening? When you are on surgery, there is, and you are giving something like heparin in a cardiac surgical patient, there is generation of thrombin. And thrombin is needed here. When you have fibrinogen to fibrin, you need thrombin, but thrombin needs to be inactivated as well by the formation of that platelet aggregation plug. Now, if that does not happen and the cross-linked fibrin clot does not form, there is one of the two. And post-CPB, you have heparin reversal with protamine. Dr. Sukesh Nair talked about it, which forms this plug. We give some antifibrinolytic agents like epsilon aminocaproic acid or tranexamic acid. But when we do this, we do see platelet dysfunction, we do see fibrinolysis, and we must know that whatever is happening and what we learned in hematology 40 years or 30 years back, it is a phasic cycle, not a contact factor pathway cycle that we've been seeing, meaning to say that one thing is going to lead to the other. So having this background in mind, what do? So standard tests, we use ACT in our labs, we use a BT-CT and a PT-INR before the surgery, and we do a platelet count. This is what we do. But heparin and APTT, if we are giving heparin, most of us in the cardiac centers do not do APTT more than once in the baseline. And when my patient is on a CPB or on an ECMO or on a VAD, I need my APTT to be with that heparin going on at some rate between 40 to 60, not 20 to 30. Now, when I use heparin, how many of us do APTT? Very few. Just the baseline, or when for 2 to 3 days post CPB my patient does not clot but does continue to bleed, or he or she goes into thrombosis. So thrombin is too much or too less in causing either bleeding or thrombosis, and both in the post-op period are bad. So when we are doing this with APTT, what do we need more? We need daily D-dimers. We need blood cultures performed to rule out sepsis, because infections also give rise to increased thrombin generation and more bleeding and oozing. Also, do not perform venipuncture for the collection of blood cultures, because there is a perfusionist sitting with the roller pump or the centrifugal pump from where you can take. Avoid these venipunctures and do the other swab and other testing for the sepsis as needed. So cardiothoracic and vascular surgery patients in the ICU, when they have undergone all this have a risk of developing anemia because of excessive drainage. And this preoperative anemia, if it was not there, or if it was there, or it was borderline with a hemoglobin of 9, you've gone and done a CABG, and your patient continues to ooze and bleed for the first 48 hours in the ICU. You have not corrected 4 things. Dr. Sukesh Nair pointed them out. One is hypothermia. Warm your patient well, because most CPB is performed between 28 to 32 degrees. We do it at 32 today, but most of the patients coming to the ICU are cold and clammy, so warm your patient well. Secondly, if you are seeing hemolysis, the second H, besides hypothermia, look for acidosis. And besides that, look for hypovolemia. And besides that, look for anemia. So rule out an anemia, rule out volume depletion, rule out drop-in or drift-in temperature, and these are blood-saving and blood-conserving techniques. Does a one-shot solution for improved patient blood management in cardiac surgery cure all? Are these 4-3 enough? No, they're not. Sometimes, despite pH being 7.34 to 7.4, despite there being no hypovolemia, there being no any problem of the 4 listed, the patient still continues to use. What do we do? And these adverse effects get multiplied. Well, this is where the STS, SCA and the AMSEC guidelines of 2021 came in the anesthesia journal, which is very popularly impacted, and they brought about multimodal, multidisciplinary approach to preserve the patient's blood and blood resources. And they said, and we wrote our own paper, Dr. Sukesh Nair was a part of the team who wrote it, that bleeding time is not enough, CT is not enough, PT, INR are needed, and with that what is needed is an APTT. And implementation of ROTAM-guided blood transfusion protocols found to have better potential to decrease blood product transfusion to improve patient outcomes was a part that we wrote from the cardiac team of the same guidelines. So when you have this coming up in many journals, then we are also worried about what has been talked about since morning, the TRALI, the TACO, the graft versus host reactions to transfusion. And we don't want it. The patient doesn't want too much of transfusion. We are today in a restrictive phase of blood transfusion. So financial consequences, more mortality, more morbidity with transfusions, what should we do? Patients are wanting something else. So in the Indian scenario, move towards restrictive blood transfusion in most of the tertiary care centers, and a primary care center should adopt the same protocols. Nurture out immediate pre-op anemia, the use of erythropoietin, the use of hypovolemia to be ruled out, patient's acid-base balance to be managed, patient's blood culture and sepsis to be ruled out. Once you've had that patient coming for surgery, in the immediate post-surgery, keep doing repeated arterial blood gases to rule out 4 things. A normal base excess, this is the best marker. If you have a base excess of plus and minus 5, your patient's pH is 7.34 ml of the arterial blood of the patient added to a small cuvette which was with heparin and without heparin. So it's called the heparinase cuvette. The moment you use a heparinase cuvette, the reagent inside obtends the effect of heparin. So if heparin is allowed to continue on a sonoclot or a TEG or a ROTAM or a multiplate, you have these viscoelastic tests which are available in plenty in India today, you will get a straight line. But if heparin is neutralized by the use of a heparinase, which is a reagent that you use in ROTAM also, ellagic acid, and when you use something like this, you get a signature curve. Dr. Sukesh told you very nicely the TEG curve. If I have time, I will like to say that use in your patients of aortic dissection with Bentall procedure done, with a liver transplant done, a rapid TEG or a TEG which is giving you or a multiplate with beyond an ACT, some curve which tells you what is the exact component that is missing. So that you're not giving whole blood, you're not giving RBC, you are giving something which is just needed for the patient's body correction, restricting your transfusion and maintaining that product at the right temperature. I'm laying emphasis on temperature and the freshness all throughout. So in CABG, The recommended test for rotum, I worked today from 2014 to 2018 was sonoclot and TEG. Today we are on rotum, and rotum has 4 channels. Extem and fiptem are together for the extrinsic pathway. So if I have a decreased amplitude of less than 7 millimeters on my rotum, for fiptem, I immediately look at the extem. The R time, the alpha angle, as well as the MCF on the extem and the fiptem, if they are less, it means my patient has hypofibrinogenemia. And what is the product with me in the blood bank, which the blood bank person can give me with increased fibrinogen? It is not packed red cells, it is not platelet-rich plasma, it is cryoprecipitate. So I will order at least 2 to 4 units of cryoprecipitate depending on how low my fiptem amplitude is, and give cryoprecipitate to this patient. Now suppose I have everything normal, I have an R time normal, I have the alpha angle normal, I have my fiptem, intim, extem, and the heparin pathway, which is intim and heptem, all is normal. But suddenly at 30 minutes, I get a tapering. Dr. Sukesh showed that, a hyperfibrinolysis. What is happening now? The platelet clot or the platelet aggregation is not complete. I don't need fibrin now, I don't need fibrinogen. But yes, I need to give to this patient a platelet-rich plasma or a platelet concentrate, whatever is available with your blood bank. So this is where the utility of the transfusion medicine and the blood bank people and the hematologists fall in. You must use heparinase in your TEG, you must use a TEG or a multiplate or a rotum with all 4 channels available, and when you're using it, you can detect trauma. Chest trauma is so common, any blunt trauma injury in orthopedics, any PPH, madam, you mentioned. We had a patient who had a cesarean done for a mitral stenosis that she had, and soon after the cesarean, baby delivered, she went into PPH. And soon after PPH, when enough cryo and FFP is given to her, the bleeding stopped, the bladder, the entire uterus was atonic, she became better. We detected on 10 days she's not doing well. We do echo for ECMO. Now, we had the echo machine in with us. We'd given everything, we did the echo, and what did we find? Her LV is dilated and she is in a dilated cardiomyopathy. A very common factor in those patients who have a valve disease like mitral stenosis, who give birth to the child is all right, but this is the precursor of maternal mortality. Either PPH, where blood products, the right kind, are not available, or a dilated cardiomyopathy where the heart failure is not taken care of by the second grade people, where an echo machine may not be at the bedside of such a patient. So have your fibrinogen, your PT and your APTT, and the mixing test that Dr. Sukesh talked about. Do the mixing test. That means you need your laboratory tests, and there are 4 laboratory tests you need. You don't need a BTCT, but you need a PT and you need an APTT. You need a platelet count and you need your fibrinogen levels. Once you've done these 4, come back, and if you're continuing on, sometimes on ECMO, we continue with a low dose of heparin infusion. I would say the 5th test is an antithrombin 3 or an anti-10A level if you're using, like we used in COVID, the low molecular weight heparin. So because heparin acts through antithrombin 3, it's a prodrug. So you all know it more than me. So at the end of the day, these are 5 lab tests which you should do, but at the same time, do at least twice in a day your rotum or your sonoclot test, and ask your administrators to give you one. This beautiful blood bank here today, I was seeing yesterday when I visited them, did not have a viscoelastic test, and I would request the administrators to have one available so that you could do this state-of-art technology in teaching in a big way, PBM, with one viscoelastic test, a test on sonoclot. I don't take commission from any of them, but I've seen my patients being saved. A sonoclot test is 600 to 700, whereas a rotum test is 2100 and a TEG is 1600. I started it as a research project, but today we have 2 sonoclots and 1 rotum in our OR and ICU, and we save our Bentals and we save our ECMO. So that's the benefit of expert learning and expert teaching, and I think I'm grateful to AIIMS that we are there. You can rule out hypothermia because you can adjust your viscoelastic testing to your patient temperature. You can detect your dilutional coagulopathy by just seeing that fibrinogen along with the PT and APTT with the mixing test from the laboratory. All these tests have a very fast turnaround time. So when your turnaround time is 10 minutes, you can easily, you are a blood banker, you can easily go and tell your intensivist, your patient's fibrinogen is less, I'm sending 4 cryo. You see the pact you make with the surgeon, the intensivist, and yourself, and you see yourself saving your patients and feeling good. So don't feel that as a blood banker, I am not clinical or I am a standalone blood banker. No. I think everyone can tie up with everyone. It is our passion to deliver the best, which you people are doing. So packed red cells, fresh frozen plasma, fibrinogen concentrates, recombinant factor 7A with tranexamic acid, all your antidotes to heparin and most of the antiplatelet compounds like protamine, desmopressin are all available. They are available. But sometimes we are fumbling. I want to give desmopressin. Can I use vasopressin? My residents ask this. No, you can't. The two are different. One has an inotropic effect, the other has an antiplatelet effect. So the two are very different. Both are synthetic analogues, but both require, they are isomers, but both require different things. So in a pregnancy, hypercoagulability is something we would be very, very determined to rule out. Again, a patient who delivered but continued to ooze in the drain, and fibrinogen in the 3rd trimester had showed 350 to 600. All patients who are bleeding need not be coagulopathic. Dilutional coagulopathy develops at a later stage, especially when sepsis sets in. And when you have consumptive coagulopathy, as you see in most of your PPH patients, if they are not given the right product at the right time, they are patients who are with PIH, especially, may go into an intrauterine death. And this is something, and why did I do this project? I have had 2 IUDs and I was PIH and I bled and there was no blood available in Aligarh where I was a PG. So talking from personal this thing, I took it upon myself to work how to give the right product at the right time so no one bleeds to death. And that's the reason why I look out at hypothermia. That's the culprit in many cases. Acidosis with basic cess and pH. And when you are giving increased volume or you're having tachycardia, you have a diabetic or a hypertensive where chances of coagulopathy are high. Your APTT is a saver if you had it done baseline with your platelet content. And visual, whatever you see is always an underestimation. So preoperative transfusion risks are seen in more than 10%. It's important to detect them, it's important to evaluate them, it's important to manage the anemia. Cross-match your RBC units well. Very often many disasters happen because of wrong cross-matching of blood, especially given in the night in the ICU by a sister who may be very sleepy or an intensivist who may not be aware that it is a B negative, which is the least that we see, or a AB negative, and you give a AB positive blood to such a patient. So minimizing the blood samples in an ICU or in an OR, having pre-op good samples and having one sample at 48 hours if your patient is doing well, or frequently at 24 hours if your patients do not doing well with your ABGs, and post-operatively doing restrictive transfusion triggers. Do not, as he said, do not be bothered by a hemoglobin of 6 or a hematocrit of 20, 25. It doesn't matter. If everything else is good, see your hemodynamics of the patients. If the mean arterial pressure is good, if there's no tachycardia, patient has a good sufficient intake output, patient's coagulopathy says there's no hypocalcemia, there's no hypothermia, there's no acidosis, there is normovolemia, and the cardiac output is more than 2.5 liters, minimize your blood samples. This is one thing that is not being done in many, many commercial private centers today. We resort to multiple tests, not needed. So that is the first trigger, that even if the hemoglobin or hematocrit is less, think of blood conserving by taking restricted blood samples. At 24 hours, once a day is more than enough, and this is well followed. Now, unfractionated heparin has many advantages. It can be neutralized, it's cheap, it's easily available. Low molecular weight heparin may, along with the other heparin, lead you to develop a thrombocytopenic purpura or a HIT. Now, heparin resistance, heparin-induced thrombocytopenia, well not done. So when you are on an ECMO or you are on an heparin infusion for long, try to taper it down so that your patient for a prolonged period does not develop gangrene, which is a marker of HIT, and does not develop any heparin resistance. If there is resistance, think of asking your blood bank to give you FFPs at the right time before the surgery can be commenced. Now, direct thrombin inhibitors have come up. Bivalirudin, argatroban, so many group 2B, 3A inhibitors, antiplatelet drugs are all in the horizon to tell us as heparin alternatives in cardiac surgery and in liver surgery, in liver transplant and in cardiac transplant. But where did we go right? Well, we were doing ECMO from 2002 to 2010. We were losing patients, 70% mortality. Our CABG improved, our pediatric patient output improved, better surgeons, better anesthetists, better team in ICUs. But what did not improve was the bleeding and the death due to sepsis. It was the coming up of the sonoclot in 2012 first, and then as a research tool, and in 2014 in our ICU and the OT, that brought about the right component and less transfusion. So from 2014 till today, we are transfusing less. And these transfusion triggers, we do not give blood till our HP falls to less than 8. This is our protocol. And then another thing that we developed was the development of learning and reading more. We had so many publications. We started our own department journal, which is well indexed now with TEMA publishers. And we brought about from sonoclot and TEG the most sensitive rotum. And when we did these tests on rotum, we could detect heparin resistance, detect HIT. We use bivalirudin. We have many papers on bivalirudin as an alternative to heparin in cyanotic and acyanotic babies. And we started to implement all this on the ground. Crash trolleys, availability of the right components, talking to the blood bank people, the sonoclot with the ABG machine available in the ICU, the other ICU has the rotum. When you have things all on the ground and the nurses are trained as much as the junior staff of MCH and DM students, we saw good results. Everyone today knows rotum less than 7, ask cryoprecipitate. It's a thing with the 60 of us who are in the ICU and OR. So we started to follow algorithms. We made our own algorithms in 2016. The first algorithm was got by Dr. Klaus Gorlinger from Germany. And at that time we used something like give more protamine, add 1 milligram per kg every time. And if the ACT was high, especially on ECMO. When we did that and we saw A10 and A15 less, we gave platelet concentrates. If our patient improved, fine. But if our lysis 30 at 30 minutes was less than 90 and there was ongoing significant bleeding, we did not either give any therapy and the patient died. We made the temperature optimum. We made the point of care tests go on, adding to the burden of economics and mortality and morbidity. So what did we change from 2016 to 2019? We went on to do heparin protamine management first. And we followed, this is what we followed. We gave antifibrinolytic tranexamic acid first. When we gave tranexamic acid first and we monitored the hypothermia and the heparin reversal with protamine, then the fibrinogen concentrate, if my A5 at 5 minutes was less than 15 or less than 30 on XTEM, if my A5 in XTEM was less than 30 and A5 on FIFTIM was more than 9, I gave the platelet concentrate. And if my CT time on XTEM was more than 80 seconds, these numbers come on the Rotem basic machine. I gave the packed CC, that is the platelet concentrates. So this is how we developed and this is how much we got. You can see sometimes If we don't have fibrinogen concentrates, we just use it in 5 patients, but you can see the number of cryoprecipitates that we were using. We were using sometimes 15 units of cryoprecipitates to obtund and overcome the bleeding, especially in our PPH patient. So thromboelastography and standard tests for evaluating platelet dysfunction and hypofibrinogenemia on VA ECMO and bleeding at our algorithm was made simpler with this. That we went on till 30 minutes with the Rotem test, and at 30 minutes we gave the right product. So with reduced product given, we saved our patient's life. So this was what we developed for our CABG patient. Here we did platelet dysfunction. The Rotem has a platelet analyzer. It's also there in platelet mapping and multiplate. You can see within 6 minutes the area under the curve after you've started your patient on heparin infusion, on an ECMO or on a CABG, and in 10 minutes you can know whether it is surgical hemostasis, if the patient still continues to bleed, and your area under the curve at A6 is less than 1. If your area under the curve at A6 is more than 5, more than 10, it means your patient is okay. And you can correlate it by using the less expensive reagents of Xtem, Intem, or Heptem and Intem. We have developed many ECMO centers and asked them to do Rotem or Sonoclot, whatever is available. And all current recommendations today are level class 2A. If we are with a level of evidence as B in annals of cardiac surgery, if you feel there is no benefit for preoperative treatment of anemia, most of the people who are in the West say there is no benefit of preoperative treatment of anemia. I think this is where we need Indian guidelines. We just have one. I was talking to Dr. Sukesh to come out with more. It is anemia, anemia, and anemia. Correction in the pre-op that brings about less transfusions in the post-op. So if you want to have restrictive transfusions, correct the anemia. Whether it is with iron, as he emphasized, whether it is to build up the hematocrit, but if once the surgery is done and the hematocrit comes down, then 8 or less, unless it is that, do not give blood. Give the right component. I would like to end here saying that preoperative antiplatelet management, pharmacological agents, tranexamic acid and ECA today, the addition of P2Y12 inhibitors to aspirin therapy, which is really causing increased bleeding in the cardiac surgical patients, and the use of preoperative anticoagulants. You have the Neoax, the dabigatran, the idrasuzumab. You have so many of them. You should not have the patient coming for surgery with these antiplatelets and anticoagulant drugs or antithrombotic drugs in them. So see to it that a good 3 to 5 days has elapsed. We recently had a CABG where we took the patient and we were told aspirin stopped 5 days back, dabigatran stopped 3 days back. Patient bled for 5 days. We kept giving so many blood. And what did the patient have? The patient had lung injury. We had to put an ECMO on this patient. The patient recovered, but there was severe diastolic dysfunction. And when we went back and took the history from the wife, who's the best person to tell the truth, even if she's unread, and the son kept saying 5 days, 3 days, he had to go back to America, so he didn't tell us the truth. But the wife said no, the drugs were continuing till the morning of surgery. So sometimes we as doctors, we as anesthetists, even if we do a PAC right, are told, given misinformation. And this is an era of misinformation. So be very careful who you take the history from. The patient himself, if he's an adult, or from the mother or the wife, they are more honest than the sons who are busy to go back, or the daughters who are busy to go back. I have no crime, but this is what I've seen in my scenario clinical practice. When you go for a PAC, the VIP patients, all people tell wrong things. They just want the surgery done and out. And the very rich is the biggest misinformant. So sometimes the most truthful are the most poor. Believe in the lady who is with the man or with the child. I at least do that. I don't believe so much of the mother. Especially when how is the nil parorally feed time. As anesthetists, we need to know that. The mother will tell you 2 hours, 3 hours. The father will come and say, 6 घंटे से बेचारे बच्चे ने कुछ नहीं खाया. So it's wrong information, but it's not right. So I just wanted to say we are still at that class 2B level of information. I'm finishing. B, and we don't know where we will be, but erythropoietin iron, reversing the anticoagulants, withdrawing the antiplatelets like tisaglor 3 days, clopid 5 days, and prasugrel 7 days before will go a long way. And in a country like India, your transfusion triggers should be 7 to 8, not 6. There are challenges. The stakeholders in PBM are too many. Funding is a very important thing, but awareness and education is what I would say, to monitor the quality like the Life Center is doing, to rule out anemia during cardiac surgery especially. And when you come back with all of them, it is important to overcome resistance from the administrators for a change. It is a new era in transfusion medicine and in patient blood management. But in India, I would like to say, we would want to have our own guidelines and not follow the West alone. I thank you all.